Good morning, everyone. And in this lecture, we are going to cover, we will try to cover these two important topics. One is called as pheochromocytoma, and the other one is called as diabetes insipidus. Um, now, what happens is, what are pheochromocytoma? I would like to start with that. Pheochromocytoma. Um, Pheochromocytoma are basically tumors which are associated with excess circulating catecholamines. Catecholamines what? Epinephrine and norepinephrine. And simply, um, when there is, like normally when we have epinephrine and norepinephrine, which is released in our body, actually all the hormones which are released in the body, they are broken down, and of course when they are broken down, their metabolites are um, either are processed in the body or either they are released from the body. For example, in this one, what happens like anyone who have catecholamines, okay, like which is basically um, epinephrine and norepinephrine, when they are broken down, when they are uh, break down, okay. So what happens, like their breaking down products, they are present in plasma as plasma free metanephrines, okay. And also um, they are present in the urine in the form of urine metanephrines, okay. So simply when someone have increased level of catecholamines in the blood or in the body, of course they will be having increased plasma free metanephrines or increase in urinary metanephrines. So of course, like before going into much detail, I would like to show you how this condition looks like. Now, we all know what are epinephrine and norepinephrine. Like these are the hormones of flight and fight. So whenever like your body is preparing for any stressful condition, like when I say stress, guys, don't take it like as a stress which is used in our daily language. Rather, in medicine, stress is any condition uh, like surgery, infection, illness, accident, trauma, things like this. So whenever we are preparing ourselves for fight and flight, of course, the sympathetic nervous system it gets activated, and once that sympathetic nervous system gets activated, what happens is there is release of this hormones which is epinephrine and norepinephrine. So now, and what are the changes it causes? Of course, we all know what are the changes they cause. So again, like what is pheochromocytoma? Uh, like um, this is a tumor, okay. This is a tumor which produces excess of catecholamines. So pheochromocytoma are frequently searched for but rarely found. About 90% of pheochromocytomas are located within the adrenal glands. 10% are bilateral and 10% are malignant. And 10% are extra adrenal, means like they are not located in the adrenal, rather some other site in the body. So you can say like this is also called as a rule of tens, right? So uh, like they say like the extra uh, adrenal pheochromocytomas develop in paraganglion chromaffin tissue of the sympathetic nervous system. 40% are not diagnosed and 5% are multiple. Okay, but 98% of the pheochromocytomas are found in the abdomen. You can see over here this photograph, they are showing you a kidney, they are showing you an adrenal gland, and they are showing you a tumor. which is producing more and more catecholamines. So anyhow, guys, like of course we are not discussing pheochromocytoma. We are discussing the diagnostics, or we are discussing the diagnostics of pheochromocytoma. But of course, like you must know what is the condition, so that's why I go into all these details. So simply, whenever these patients they have more and more norepinephrine and epinephrine, what happens is they had episodic symptoms like headache, sweating, palpitations and tachycardia, hypertension, anxiety, pallor, nausea, abdominal pain, weakness, weight loss. Now, whenever there is palpitations and tachycardia with hypertension, after the attack they may have polyuria, and in response to that, and they sweat a lot, so they drink a lot, so polydipsia. So anyhow, I think like all of these symptoms, why they are occurring is quite clear. Is simply because there is too much epinephrine and norepinephrine or catecholamines in the body. And now the point here is to establish how we diagnose that. And in the diagnosis, I already told you that catecholamines break down, and the breakdown products, or their metabolites are present in the plasma as plasma free uh, metanephrines or urinary metanephrines. So simply, guys, what we do is uh, diagnostics are very easy in this case. We check the blood and urine sample for metanephrines. Okay. If their levels are high, so it suggests, I'm not saying the diagnosis is done, I'm saying suggest, or you can say increased levels suggest pheochromocytoma. Okay. One of the thing, again, like we talk about the suppression test, like saline suppression test, dexamethasone suppression test. Uh, if the levels in the blood and the urine are not so high, we can use a test in this case called as clonidine suppression test. Okay, so we do a test called as clonidine suppression test. Uh, Again, a very interesting type of test, you can say. So now, like of course, clonidine is a drug, okay, and what happens like this drug is used to treat high blood pressure as well as many other conditions. For example, in kids, we can give it in case of some behavioral disorders as well. So you can say like whenever uh, we give the person clonidine, okay, so the levels of plasma metanephrine should be suppressed, okay, the levels of plasma metanephrines should be suppressed, okay. Again, like to understand this thing, we have to go into you can say the pharmacology of this drug, or the mechanism of action, what it do. Basically, it stimulates the alpha 2 receptor in the brainstem, and it decreases the peripheral vascular resistance, as well as it suppress the release of norepinephrine. Okay, so what it means, when we give clonidine to a normal person, the epinephrine and norepinephrine are suppressed. But when we give someone clonidine who have pheochromocytoma, and we measure the plasma free metanephrines after this test, like uh, and we don't found the decrease in the level of meta, what you can say, epinephrine or norepinephrine, that is again suggestive of pheochromocytoma, right? So of course, like when we have measured this thing or we have done this thing, and we found like the patient have the features, uh, including the history and examination, we think like the patient have suggestion of pheochromocytoma, then of course the next thing is to find out where the tumor is located, and for that of course we can go for imaging. For example, I show you this one. It's a CT scan. We can do MRI as well. And one of the thing, in pheochromocytoma, what you can say, a very, what you can say, a different test we do, or what you can say, a scanning we do. Okay. Well, I will tell you about that after discussing this thing. See, once you are suspecting pheochromocytoma, so of course, if you remember, I show you here frequently searched for but rarely found. So, uh, see, abdominal CT scan is very important. Why? Because most of the tumors are in the abdomen, and here the pointer is showing like this patient have a tumor in the abdomen, right? So, simply we go for the imaging. Okay, we can go for the CT scan, we can go for the MRI of the abdomen, and MRI of the chest, MRI of the head and neck. 2% of tumors are located over there as well. We can go for PET scanning. Okay, so we can go for anything. One of a very important scan, which I don't know, like you have to remember now or in the internal medicine, but that is called as MIBG scanning. So what is MIBG scanning is basically, uh, this one is simply used to diagnose, what you can say, um, this pheochromocytoma. Okay, so what is MIBG is basically it is meta iodo benzyl guanidine. Okay, it is meta iodo benzyl guanidine. Okay, so basically what happens is, you can say, we use MIBG radio labeled scanning. Okay, and that help us in localizing the tumors like pheochromocytomas or neuroblastomas, things like this. So this is about MIBG scanning we can do in these patients, right? Next condition which we are going to study is, of course, polydipsia. Okay. Now, what is polydipsia? Is uh, sorry, diabetes insipidus. Diabetes insipidus. So now, what is diabetes insipidus? Basically, there is something called as psychogenic polydipsia. What is psychogenic polydipsia? Anyone who don't have any problem in the body and someone who is drinking more water every day, uh, as a habit, or what for whatever reason, of course he will pass more and more urine. Okay, and that's what happens in diabetes insipidus as well, that like these are the patients who pass basically more urine. Okay, so simply diabetes insipidus and psychogenic polydipsia, why I am discussing these two conditions, because they pass too much urine, or they have polyuria. Okay, they pass too much urine and they become thirsty as well, so they have poly dipsy as well, so drinking a lot of water and passing a lot of urine. Okay, now, um, again I will show you some um, very common type of very easy type of thing. This one is one of the thing. Okay, now there is a hormone called as ADH, which is what? Antidiuretic hormone. It is also called as what? Vasopressin. Uh, I hope we can see this photo clearly. It's a very important photograph. I don't know like how clear it can be in front of you. Okay, but I will try to make it as big as we can. Okay, what is the function of ADH? Okay, or anti-diuretic hormone. First of all, if you will pay attention on the name, it is ADH, anti-diuretic hormone. Okay, so anti-diuretic means what? It is going to stop diuresis. Okay, anti-diuretic hormone will do what? It is going to stop the diuresis. So Simply, this is a hormone, or antidiuretic or vasopressin is a hormone uh, which is what you can say maintaining the water balance in the body. Okay, so this hormone is basically you can say formed in the hypothalamus. Okay, it is formed in the hypothalamus. Okay, and now it is going to store in the pituitary. Okay, it is formed in the hypothalamus and it is going to store in the pituitary. Now what happens, like whenever the plasma osmolality, or whenever you can say there is less water in the blood. So of course less water in the blood means what? There will be hyperosmolarity. The osmolarity of the blood will be increased. So now the body knows that, okay, body needs more water. So antidiuretic hormone is released. When antidiuretic hormone is released, what it does, it asks the kidney to uh, retain or conserve more and more water in the body. Okay, to make the blood dilute or to make it isotonic. Simply, now there can be two conditions. One is central diabetes insipidus, when there is this hormone ADH, which is also called as vasopressin, it is not released by pituitary, or the problem is central. We call it as what? Central diabetes insipidus. Then there is something called as peripheral or renal diabetes insipidus. In that, those patients, the ADH is released, but the ADH cannot act on the kidney. Okay, the ADH is released, but the ADH, like the kidneys, don't respond to ADH. So we can also call it as renal diabetes insipidus or peripheral diabetes insipidus. So see, normally when you drink less water, when you drink less water, if you are a normal person, your pituitary will form ADH. And when your pituitary will form ADH, your kidneys are going to save more and more water. So less urine will be formed, right? So a normal person, whenever we drink less water, simply our kidneys conserve water and form less urine. Okay, very easy. I'm not talking about like that. Okay, so now, for example, someone who says that, I drink a lot, I pee a lot. What should come into your mind? Diabetes mellitus, diabetes insipidus, and psychogenic polydipsia. So if it is psychogenic polydipsia, okay, so if we will don't if we will not allow that person to drink water for example for 10 hours, so what will happen? Because his everything is normal, so he will start making less urine or concentrated urine. But if we will stop a diabetes insipidus patient to drink less water, because there is problem in the body, in the ADH or in the kidneys, when the ADH cannot act, so they will keep on forming diluted and more urine. Understand? This is the point. Why? And diabetes mellitus is a different story. So you can see over here central diabetes insipidus and nephrogenic or peripheral diabetes insipidus. What are the causes? Familial hypothalamic diabetes, tumors can be there, craniopharyngioma or other tumors, trauma and head surgeries can be there. And in the periphery one, uh, it could be acquired nephrogenic diabetes, or increased hypercalcemia can cause, hypokalemia can cause, or lithium drugs can cause. Okay, and this is primary polydipsia. Simply anyone who drink a lot of water, or anyone who, if you will give them IV a lot of water, of course they are going to produce more and more urine, right? So now what is central? The problem is in the pituitary or hypothalamus, or in the brain. Simply central. What is this one? Peripheral. The problem is in the kidney. Nephrogenic. There is ADH, it cannot act. Okay. Now the diagnosis works like this, guys. Very, very, very easy thing. If you understand this concept, that the rest of the points are very easy. So simply, I was talking about when someone have the combination of polyuria and polydipsia, there are two major causes. Okay, polyuria and polydipsia, two major causes. Of course, three, but diabetes mellitus we will study. Okay, make it three, by the way. Three major causes. Diabetes mellitus. Okay, we will study it later. Diabetes insipidus. Okay, and psychogenic psychogenic polydipsia. Now we can do one blood sugar test and we can rule out this thing. Rest is two things. Now guys, how we make the diagnosis. Okay, so patient with psychogenic polydipsia, simply they drink fluid in excess, either due to psychological reason or psychiatrical reason, right? So you can say the lab diagnosis of this condition, how we differentiate, how we go. So how we differentiate or how we go. Of course, in diabetes insipidus, there is a problem with antidiuretic hormone. ADH normally acts on the collecting ducts in the kidney to stimulate water absorption. If ADH is not functioning properly, too much urine will be passed. You can see this one, right? In turn, the patient becomes relatively dehydrated and drink to compensate for this. Okay. So this thing is important, right? And as we know, there are two forms. One is called as cranial or central, one is called as nephrogenic or peripheral. So in this one, the problem is the release of ADH. Okay. So if we will check the blood level of ADH in this case, ADH will be low. In nephrogenic, the ADH will be not low, will be normal, but it means what? That it fails to exert its effect on the kidney. So the first test, guy, which we can do is water deprivation test. Okay. Now, what is deprivation test? If we restrict any patient for the intake of water, if they have psychogenic polydipsia and we are not allowing him to drink water, what will happen? He will form concentrated and less urine. But if the patient have diabetes insipidus, even if you will restrict the water, he will keep on producing more urine and diluted urine, and he will become dehydrated. Okay, so water deprivation test to rule out psychogenic polydipsia. Okay, so now you have ruled out this thing. Now the second thing is what? Now you know if water deprivation after stopping water, still it is producing a lot of urine and dilute urine. Now what will happen? We are going to go further. So basically what we do, how we do the test is, in water deprivation test, when the patient people wake up in the morning, okay, we test their blood and urine osmolarity, okay, every hour for 8 hours. Okay, so after waking, we check plasma and urine osmolarity every hour for 8 hours. Okay, and we take a record. Okay, so psychogenic will pass concentrated urine. Okay, so the concentrated urine means what? The urine osmolarity will be high, but diabetes insipidus will produce low osmolarity urine. Okay, now the next point is what? The next point is simply to differentiate two forms. To differentiate two forms, what we can do? We can do a test called as desmopressin test. Now, what is desmopressin, guys? It is a synthetic form of ADH. Okay. When we give ADH to a patient, okay, of course, in cranial DI, in central diabetes insipidus, there is no ADH. So when we give them ADH, they show improvement. Okay. In nephrogenic or peripheral one, diabetes insipidus, there is no effect. Understand? Why? Because the kidneys, they cannot respond to this thing. Okay, so this is what you can say, uh, the lab diagnosis of very, very, very easy, guys. It's not difficult at all. Okay, it's very easy thing. So guys, that's all for today, this lecture, and I'm going to talk about other conditions in the next lecture. Okay, so like next lecture will be probably about diabetes. Okay, and we are still in endocrinology, and on after endocrinology we are going to study or talk about the rest of the things. So see you guys in the next lecture. Thank you so much for listening.